Hello, everyone. Welcome to the PNP Pals Hope Zoom call. I have muted everyone today as they enter, as we do have a physician presentation today. So we can manage the presentation a little bit better. We're going to keep folks muted today, but we are super happy to see everyone, and we will definitely get to all your questions today. Thanks for coming. We're so happy you're here. We're excited to have Dr. Deepa Magge from Vanderbilt University to talk about peritoneal disease management and should we take an aggressive approach or not. We are super excited to hear that presentation. It is a big group today. And Anna Maria, thank you very much for using the chat function. We do encourage use of the chat throughout the presentation. This is a great way for you to connect with people. And if you hear stories or see folks that you resonate with, feel free to share information. Feel free to send us an email at zoom@pnppals.net, and we'll make those connections discreetly in the background too, checking in with one another to make sure everyone's okay for introductions. So many faces today. I'll get it out of the way right now. This is the highlight of my week. I couldn't be happier than seeing all of you here. So thank you for being here. We're so glad to be able to do this with you. I will go ahead and I'll do a quick introduction. Dr. Magge will do an introduction. There's a couple board members I'd then like to go to who can give some introductions and say hello, but I wanted to start with you and welcome you and thank you for being here and bringing your expertise on this important subject. So I'd like everyone to welcome Dr. Deepa Magge from Vanderbilt. Thank you for being here.
Thank you for having me. It's such an honor to be a part of the group and to be giving you guys this lecture today and hopefully demystify some of the mysteries behind peritoneal disease. So I'm happy to be part of this.
We appreciate that. And I'm sure this will be educational for everyone. I personally have been doing this as a survivor for 16 years, and I learned something from every presentation, and that's not hyperbole. So we very much appreciate you being here. And I am Chris Piekarski. I'm the president of PNP Pals. I'm honored to hold that position. I'm also very grateful for the team that supports PNP Pals. Adele Jason is our vice president. Adele, would you say good morning to everyone?
Yeah, hi everybody, welcome. I think I know most of you. So so a 9-year survivor and doing well, but like Chris and the rest of the team, so honored that Dr. Magge is here today to share her knowledge and really her inspiration. I think these surgeon presentations inspire us as patients. So welcome, everybody.
Thanks, Adele. That's terrific. And then I'd like to introduce Charmaine Skillman from our board also. Charmaine, would you say hello?
Hi, everybody. I'm Charmaine in Austin, Texas. I was diagnosed 23 years ago and had my CRS and HIPEC 11 years ago, and I'm doing fine. And so glad to be a volunteer working for PNP Pals. It helped me get to Dr. Sugarbaker for my surgery, and I want to help other people find the right treatment, just like I got help from Pals.
Never get tired of hearing that number, 23, one of my greatest inspirations. And you never know what's going to happen with this disease. So we're so grateful for all you're doing, Charmaine. I'd also like to introduce 2 of the moderators from the Appendix Cancer PNP Facebook support group. So James Caldwell from Ireland, if you'd like to say good morning and good afternoon to folks.
Good afternoon, everybody. James Caldwell from Northern Ireland. I'm a 6-year survivor from high-grade mucinous adenocarcinoma. And as Chris says, I'm an admin on the Facebook group. Everybody's welcome. And thank you, Dr. Magge, for coming and giving us this talk.
Thank you for your tireless and thankless work. Really, we appreciate what you do to facilitate that forum. A lot goes on there. There's over 4,000 members there. It's a great place that we do endorse for information. Yeah, we thank you for monitoring that traffic. And then likewise, Michael Healy, also from Ireland, if you wanted to introduce yourself, he is also one of the moderators.
Hi guys, great to see everybody this morning, afternoon. Michael Healy from the south coast of Ireland. I'm a 9-year survivor, a low-grade surgery in Basingstoke in the UK. Currently doing fine. So great to have everybody on board, and great to have yet another expert to unmystify this whole complex scenario that everybody finds themselves in. So nice to meet you all.
Always great to see you, Michael. I'm going to go through just some introduction slides. Adele, can we see the slides okay?
Yes, yes.
Perfect. Well, welcome to the HOPE Zoom call, folks. And just some disclaimers. So please remember that we are not licensed medical physicians. We do have one here today, but it's vital that you have your own team of licensed physicians and qualified medical professionals as you treat this disease. So we'll give you some ideas, we'll point you in the right direction, but you must seek advice from your team of physicians. We have reviewed the presentation today. We do not think there's images that will be scary or data that's scary. The images are drawings, they won't be too graphic. It will be educational for sure, and we find educated patients do better. Please remember that participating in this forum means your identity and health condition may be shared with the public. We do record these, especially the physician presentations, and they will be shared for the community's benefit. And then finally, by participating in the event, you do share permission to share your likeness with patients, caregivers, and other interested parties. So we thank you for being here. Today, we do try and keep these to a very strict timeline. We'll be going for an hour and a half today. So we're excited for that conversation with Dr. Magge. These have become incredibly popular. You'll see we've got quite a few people on today from around the world. And so welcome and thank you for being here. We want you to know we are here for you. Do not feel obligated to stay for the whole hour and a half, especially for patients on treatment. That can be a long time. So stay for as much or as little as you want. Don't have that feeling of obligation. That's the last thing that we want. We do encourage use of the chat. I mentioned that before. And so use that liberally. And again, we'll keep it to an hour and a half. Finally, you can stay connected with us throughout the week at Facebook on the PNP Pals network and Instagram at PNP_Pals and on our website, pnppals.net. And while that is under construction right now, and we are working on improving that, we ask for your patience, but we know that's going to be bigger and better. We switched servers. Dr. Magge, maybe we should call your husband and ask for some of his IT expertise.
I will try again. Here we go.
And with that, we will turn to Dr. Magge and welcome you again. And we're looking forward to seeing your presentation, and I'll let you take the floor.
All right, sounds good. Thank you very much, Chris, for having me here today, and Adele for organizing all this. It's been a pleasure to work with you guys, and it's really an honor to be presenting here today. I think, you know, as somebody who manages a lot of patients with peritoneal disease, it's a very challenging disease process, and especially because there are a lot of unknowns. And I hope to give you a little bit of information today. And if you have any questions, please feel free to ask throughout the presentation, or you can save them till the end of the presentation. I'm happy either way to answer all of your questions. Just a little bit about me. I did my general surgery residency and surgical oncology fellowship at University of Pittsburgh Medical Center. I did 2 years in Dr. Dave Bartlett's lab, where I focused on vaccinia virus in the management of colon cancer, but I did a lot of research in peritoneal disease and a lot of retrospective analyses during that time. After completion of fellowship, I spent 3 years at Mount Sinai Hospital in New York City. I was there through the start of the pandemic. I have a 2-year-old son, and we felt that New York was no longer the right place for us. So I took a position as director of HIPEC in the peritoneal disease division here at Vanderbilt. And I started here in the beginning of September. So we have a great peritoneal disease HIPEC program here, and I'm happy to take care of any patients that come my way. And if you have any questions or concerns, please don't hesitate to contact me. My contact information will be at the end of the presentation. So with that, I'm just going to start. My presentation is titled Local Regional Therapy for Peritoneal Carcinomatosis, to be aggressive or not to be. I have nothing to disclose. So the presentation today will discuss a little bit about the background of peritoneal disease, how we best manage this disease process. I'll discuss a bit about the technical sides of the cytoreductive surgery HIPEC procedure. I'll discuss why we use the agents that we do use during the procedure. I'll discuss the preoperative planning that goes into management of peritoneal disease from different disease processes, not only from appendiceal cancer, but also all the way ranging to ovarian cancer. I'll discuss a little bit about the research and outcomes. I'm not going to go too much into detail in this presentation, but after that, I will answer any questions that you guys have for me. So I think the important words that I use constantly with patients and in lectures in discussing peritoneal disease and management of peritoneal disease are biology of disease and tumor burden. Those are the two biggest phrases that I constantly use in discussing management of this disease process. What do these words mean? So biology of disease really refers to how aggressive or indolent is the process. And we get a sense of that biology based on response to whether they get neoadjuvant chemotherapy or chemotherapy prior to surgery, or we get a sense of the evolution of the disease. So how long has this disease been going on for? How long has it taken for the disease presentation to occur? And that gives me a sense of how aggressive I should be against it from a surgical intervention standpoint. Tumor burden really refers to exactly that, the extent of the disease, how much carcinomatosis is present there. And am I going to be able to do a complete cytoreduction or debulking procedure on this patient? Because if I'm not, I don't think there's any significant benefit to providing a surgical intervention at that time. So those are the two most important things that go into my decision-making in regards to whether I can offer a surgical procedure for patients with peritoneal disease. So a bit about a bit of background about peritoneal disease. So peritoneal dissemination from GI and gynecologic cancers is quite common. The most common primary tumors that result in peritoneal disease are the appendix, and appendiceal tumors range all the way from low-grade mucinous neoplasms all the way to high-grade adenocarcinomas of the appendix, including those with signet ring cell features. We also see peritoneal dissemination from colorectal cancer primaries, gastric cancer, and ovarian cancer. Primary peritoneal malignancies are a little bit less common. So that's referring to peritoneal mesothelioma. We do see those patients. There was a high population of peritoneal mesothelioma patients in New York because of 9/11. We have a very big population there. So I was treating a fair number of peritoneal mesothelioma. But here in Nashville, we actually don't have a huge population of those patients. Recurrence of a lot of malignancies is often confined to the peritoneal cavity. And I consider peritoneal disease a very different disease process than somebody who has liver metastases and lung metastases. Whereas the patients with solid tumor metastases, such as liver metastases and lung metastases, we believe these metastases occur through a hematogenous fashion through the bloodstream. Peritoneal disease, I consider more of a local regional problem. So the analogy I often give patients in the setting of an appendiceal tumor, for example, is the appendix is similar to a balloon that's filled with ink. And if there's a microperforation or a small tear in that balloon, you can get some of that ink that leaks out and splatters around. And in a similar fashion, the appendix, which may have a primary tumor within it containing jelly or mucin, if there's a microperforation in that appendix, some of that mucin can leak out and cause this splattering and resulting in tumor deposits. So I consider peritoneal disease a local regional problem, whereas patients with liver metastases and lung metastases, I consider that a systemic disease process. So whereas we used to see a significant mortality from patients presenting with peritoneal carcinomatosis, we are now using aggressive surgical techniques as in continuity with chemotherapy, as well as radiation in some settings, to provide patients with a really long duration of life, as well as in some rare occasions, providing a curative technique. And I have to say that with a caveat, to be perfectly honest, because I don't use curative very often. But in very small, certain situations, it can be considered curative. So cytoreductive surgery is not a novel technique. It's actually been around for decades. So cytoreductive surgery itself is the debulking portion of the procedure, and it's actually been performed for decades, since the 1930s, in the setting of ovarian cancer. So the goal of the cytoreductive surgery really is to remove the macroscopic disease, or the disease we can see and feel, not only to palliate symptoms, but to remove all of the gross disease so that only microscopic disease remains. It used to be performed primarily for a palliative option, but now we're using it more for treatment. The HIPEC portion, or the hyperthermic intraperitoneal chemotherapy portion of the surgical procedure, is meant to treat the microscopic disease. So this has actually also been around for decades, since the 1980s. And the whole goal is to remove all of the gross or macroscopic disease, so only the microscopic disease remains at the end of the debulking portion of the procedure, so that the cytotoxic drug that we infuse into the peritoneum can have direct contact with the entire peritoneal surface. And that is meant to give high dose chemotherapy strictly to the peritoneal surface and treat the microscopic disease. So this is just a picture here of what we often find with patients with peritoneal disease. These white spots in the picture represent some of those tumor nodules that we do encounter in the abdomen when we do our diagnostic laparoscopy. And oftentimes we do a diagnostic laparoscopy up front in order to determine the extent of disease or the tumor burden. And the goal of the cytoreductive surgery really is to remove all of these spots that you're seeing on the peritoneal lining, or involvement of solid organs, and give you a maximal debulking, essentially. Really, the rate limiting step in the ability to be able to do a complete cytoreduction is the involvement of the small intestine. When I see significant small intestinal involvement, I do not want to make that patient's quality of life post-surgery inadequate, meaning you cannot remove somebody's entire small intestine. So that really is, and have a good quality of life after surgery. So that really, to me, is the rate limiting step in my ability to be able to provide a surgical intervention for the patient. So oftentimes what I would do is perform a diagnostic laparoscopy, assess the small bowel involvement. And if the small bowel involvement is not significant, then I would offer them the full Monty, essentially. So the rationale for HIPEC and the heated intraperitoneal chemotherapy, it's really based on the fact that we know that systemic chemotherapy, or the chemotherapy we get through the port, is not very efficient at treating intra-abdominal tumor dissemination. Many studies have shown that. There's a poor blood supply to the peritoneal surface, and there's low penetration of the systemic chemotherapy into these peritoneal nodules. And so we felt that direct contact with these cytotoxic agents would be the most effective in terms of treating the peritoneal disease. Additionally, we know that the peritoneum limits the drug diffusion into the peritoneal space. So we're not getting the same effects that we get through the bloodstream to liver tumors or lung tumors that we get to the peritoneal surface. So in order to be able to overcome that barrier, you'd have to give really, really high doses of chemotherapy, and patients can't tolerate that. And so that's why the hyperthermic peritoneal chemotherapy procedure came into play, to be able to directly treat the peritoneal surface with these cytotoxic agents. So we know that we're allowed to give really high local concentration of specific agents, because many studies have been done with different agents to look at whether these are taken back into the bloodstream and cause systemic toxicity. The agents that we have studied and we use have very limited systemic toxicity, which is why we use them. That being said, there are some side effects that we do see with the HIPEC agents we use, but they're much limited compared to systemic therapy. So the whole point of the procedure really is to remove all of the disease we can see and feel, and then treat the microscopic disease with the high dose chemotherapy introduced into the abdomen. And this is just a diagram or schematic of what we do. I use what's called a closed technique, which is essentially where after we do a complete cytoreduction, we place an inflow cannula into the abdomen as well as an outflow cannula into the abdomen. And we connect these to a bypass machine. Similar to what you see in a cardiac bypass, we connect it to the bypass machine. And after we reach a specific temperature, we introduce the chemotherapeutic agent through the inflow cannula, and then you're constantly getting this circuit of inflow and outflow. So it's not just staying in the abdomen and sitting there. You're getting this constant circulation of this chemotherapy. And the hyperthermic portion of the case works in tandem with the chemotherapeutic agent to give you the most cytotoxicity, essentially, of the tumor cells without causing normal cells to have degradation. So many studies have looked at how much you have to debulk in order for the HIPEC to actually work. And what we know is that the tumor deposits left behind after you do your cytoreduction have to be less than 2.5 millimeters in depth, which is very, very small. So you really have to be able to do a very good debulking in order for the HIPEC to actually be beneficial. So my policy is, if I cannot debulk to get the tumor deposits down to 2.5 millimeters, which is somewhat of a, based on my eye and based on, practice and doing this for a while, I won't do the HIPEC portion of the case. So in order for the intraperitoneal chemotherapy to actually be beneficial, you really have to do a good surgical debulking. So the cytotoxic drugs that we use, they have been studied also very vigorously, and we know that they have to be large, they have to have a high molecular weight, they have to be hydrophilic, and they have to be ionized in order to work well. So this is just a listing of some of the agents that we use. The most common agents that we use are mitomycin C and platinum agents. I most commonly use mitomycin C for my GI malignancy groups. I use the platinum agents for patients with mesothelioma and ovarian cancer that have peritoneal disease. But mitomycin C has been kind of our tried and true chemotherapeutic agent that we use here in the States. I think Europe uses different agents, and they use a lot of cisplatin and oxaliplatin. So countries do things differently, and that's one of the issues with this procedure, is that the data can be very confounding because people do this procedure somewhat differently from institution to institution. But in general, the majority of surgeons in the US use mitomycin C for the majority of their GI malignancies. And mitomycin C has been shown to have very low systemic uptake and very low systemic toxicity, and that's why we use it.
Dr. Magge, do you ever rely on chemosensitivity as a, a yardstick, an indicator directionally?
Say it one more time, I'm sorry.
Chemosensitivity testing?
Yes, so that's a very good question. So for patients such as, for patients with colorectal cancer that are platinum sensitive, based on their chemotherapy, if they're platinum sensitive, I typically still use mitomycin C for their first HIPEC. If they recur within a year or 2 years, if I'm planning on a second procedure or a second HIPEC, I do use a platinum agent. Now, if they're platinum resistant, I would never switch to a platinum for the second procedure.
Yeah. And does your discretion change if there's a big gap in time? Because we do have patients who have recurrences after 10, 15 years.
You're 100% right.
In rare instances.
It does.
Yeah.
So, platinums are very great agents, but they do have more renal toxicity. So you do have to be careful with the use of them. And that's why I preferably use mitomycin C. So even if the time period or the disease-free interval is longer, let's say 10 years, I would probably stick with mitomycin C for the second HIPEC and not switch over to a platinum agent. But if the disease-free interval is quite short, and I don't offer a second HIPEC if the disease recurrence is within a year. I don't think there's any benefit to that. But if it's longer, if it's between a 1 to 2 year disease-free survival or disease-free interval, then I would offer a platinum agent for their second HIPEC. Does that make sense?
Yes, it does. Thank you very much. Can we pause for a moment and explain what chemosensitivity testing is? In my layman's terms, what I would tell the group is that's where we get a sample of the tumor, we send that to an outside lab, and they will actually test multiple chemotherapies to see which chemotherapy the tumor responds to best. That is not an FDA approved procedure. That's a laboratory procedure that gives us some directional information to use in care, but it's definitely not something that's going to be reimbursed. Do I have that right, Dr. Magge?
That is exactly right.
Okay. Yep.
Any other questions?
Thank you.
Before I move on?
I'd say keep plowing ahead.
All right.
I'll look for hands raised.
Sounds good. So I talked a little bit about the direct cytotoxicity of the chemotherapeutic agent itself when used in HIPEC, but there's also a role of the hyperthermia component. So why do we heat the chemotherapy? What is the benefit of heating the chemotherapy? So multiple studies have shown that the hyperthermia actually enhances the efficacy and penetration of many of the drugs that we use. So the heat itself can cause direct cytotoxic effects. It can cause some protein denaturation. It can induce apoptosis, or it can induce the cells to die. So you have to be very careful, because normal cells can also die if you put the temperature too high. So we're very strict about keeping the temperature range between 41 to 43 degrees for our outflow temperatures, because if you go above 43 degrees, you do get normal cell protein denaturation and normal cell death. So we're very strict about maintaining that hyperthermia temperature range. Additionally, the hyperthermia can induce vasodilation, which increases the effect of the chemotherapeutic agent. So during this HIPEC portion, or during the hyperthermia portion, we do see a lot of hemodynamic changes in patients cared during the operation. So we're very vigilant during this time for changes in patients' heart rate and blood pressure, and maintaining those things during this portion of the procedure, because we do see changes in their hemodynamics during this portion. So we do see a synergy of drug and heat causing tumor cell death, essentially. So this synergy of the chemotherapeutic agent and the hyperthermia really occurs best between that 41 to 43 degree range. So like I said, normal cells start to die after 43 degrees. So we're very strict for keeping this temperature range between that 41 to 43 degree range. And we know that the cytotoxic drugs work best also in that range. So we're very closely observing the outflow temperatures during the HIPEC portion of the case. We do this procedure immediately after debulking or doing our maximal debulking. We do the HIPEC portion so we can get all of the surfaces of the peritoneum exposed to the hot chemotherapy. And some patients ask, why not do these in separate procedures? Why not just do the debulking first and then bring them back and do the HIPEC portion on another day to limit the length of the procedure? And the reason we don't do that is because once you do a surgery, you get a lot of scarring, you get a lot of adhesions. And so when you bring them back for a second procedure and they have a lot of scarring, you're not going to get all of the exposure of all of the abdominal surfaces, of all of the small bowel surfaces to the hot chemotherapy, which is really what we want for this procedure. So that's why we do this all together at one sitting. And this accounts for a very long day, both for surgeon and patient and families, which can be very tough. But that's really why we do it all in one sitting rather than break it up into two days. It really prevents compartmentalization due to scarring and allows all of the surfaces to be exposed to the HIPEC. So what goes into determining if a patient is a candidate for this surgery? And it really goes back to my second slide where I discussed tumor burden and the biology of the disease. So the patients that I offer this procedure to it depends on initially their pathology. So for appendiceal tumors, for low-grade mucinous neoplasms ranging to high-grade adenocarcinomas, for low-grade mucinous neoplasms, I will offer surgical intervention up front typically because those patients don't typically respond to systemic therapy due to the indolent nature of the low-grade mucinous neoplasm. However, on the other end of the spectrum with high-grade adenocarcinomas, which are invasive, they do tend to respond to systemic chemotherapy because they do tend to be a little bit more aggressive and the cells are more rapidly dividing. So they do respond to systemic chemotherapy up front. So for patients with low-grade mucinous neoplasms that have a disease burden that is debulkable, I'll do a surgical resection up front. And most of the time, those patients do not receive chemotherapy on the back end. However, the high-grade adenocarcinomas of the appendix, I typically treat with systemic chemotherapy up front, followed by re-imaging after 3 to 6 months. And if they have stable disease or response to the chemotherapy, then I would consider them a candidate for this procedure if the tumor extent is not significant. So the two things that really go into play here are the biology. So is it a low-grade process or is this a high-grade aggressive process? And then what is the tumor extent or what is the disease burden? And the way we determine the burden of disease is using a peritoneal cancer index or PCI score. And PCI is based on basically a quadrant system of the abdomen. As you can see here, we break up the abdomen into 13 sections ranging from 0 to 12. And we give each of these scores, each of these quadrants a score between 0 to 3. And we add up all of these scores at the end. So you can have a PCI of 0, which you wouldn't undergo a procedure for, all the way up to 39, which is the maximum PCI you can have. What we do know is as the PCI goes up, the morbidity of the procedure goes up, or the complication rate goes up, and the success of the procedure goes down. And so my policy is really for low-grade processes that I know probably will not respond to systemic chemotherapy, I'm definitely more aggressive. So even if the PCI is a bit higher, I tend to be a bit more aggressive for those patients than for patients with high-grade processes that do respond to systemic chemotherapy that likely would not benefit from a major surgical intervention if their PCI is very high. So the two things that really go into my decision making in determining whether a patient is a candidate for surgery is really their PCI score, which I base often on not only the CT imaging, even though CT imaging can be incorrect. I base it also on diagnostic laparoscopy, where I put a camera in and I take a good look at the abdomen and really get a sense of the tumor burden. So that's kind of my policy. For low grade processes, I tend to be more aggressive. For high grade processes, I tend to treat with systemic chemotherapy up front, make sure that their biology is favorable, meaning they have a good response to the chemotherapy and they don't progress on chemotherapy, and then determine if they're a candidate for the surgery.
Burden in biology, just as you said at the
Correct.
beginning.
Those are really the two major factors that go into any of my decision making for this process.
There was
Yeah,
a question.
Dr.
I'm sorry.
Go
Go
ahead.
ahead, Del.
I was going to
Go.
read the same question. What's considered a high PCI? That's one of the questions that just came in the chat.
So I actually use different numbers. So the data has shown PCI greater than 15 is associated with poorer outcomes. So for low-grade processes, so for low-grade mucinous neoplasms of the appendix, I don't really have a cutoff. So as long as the small bowel is not significantly involved, and I feel like I can give that patient an adequate cytoreduction, meaning, and I'm going to go into what an adequate cytoreduction is here in a minute, then I proceed with surgery. For a high-grade process, on the other hand, I actually use a much lower PCI. So PCI for me, less than 10 is where I feel like that patient is going to really benefit from the surgical intervention, because typically PCI greater than 10 is associated with, a longer hospital stay, a delay in getting their adjuvant chemotherapy or chemotherapy on the back end. And so I kind of use a lower number than what some of the studies have shown. And all surgeons are a little bit different, but in my eyes, I think patient selection is really the most important thing in getting good outcomes. And I think if you use a higher PCI cutoff for high grade processes, you likely are not going to get long-term survival for patients. So my policy is a little bit stricter in terms of high grade disease, but for low grade disease, I tend to be more aggressive, if that makes sense.
Absolutely. And I am going to pause at this moment and just remind patients that, first of all, Dr. Magge brings this knowledge from deep experience at UPMC. She explained her retrospective analyses earlier. And UPMC has a wealth of knowledge. So that is her experience, and that's what she's comfortable in doing for patients. But as she said, different surgeons have different approaches and different limits in their mind. So, at least in the United States, right? This is obviously a global team and a global call. In the United States, we have access to the greatest care in the world, and we have the option to seek out care from different physicians. Each case is individual, and you can seek. There's surgeons that we know are more aggressive, so keep that in mind. Each case is individual, and we see the rules broken all the time. But
I break the rules all the time too. So I think that's one of the really important points that you make, Chris. I think we all have these general ideas in our mind that we try to follow, and we all have very good training and you can get. I think the key really is to go to a high volume center, an academic center that is experienced in doing this procedure, and you will get wonderful care. And I think that really is what it comes down to. And my personal bias is to be more aggressive for low grade processes. But do I break the rules? I do break the rules, especially for younger patients who I feel have no other options. I definitely do tend to be a little bit more aggressive, but my general policy is what I mentioned before. But there's so many fantastic surgeons in this nation, as well as in other countries, that do this day in, day out. And I'm sure everybody is getting really good care. But one of the biases I have is really high volume center, academic center, somebody who does this a lot, because patient selection really is very important.
That's awesome.
Thank you. You know, we did have two more questions
Yeah.
pop up in the chat, and we might as well address these
Yeah, sure.
now. What are some side effects of mitomycin C that you typically see?
So some of the major side effects we see when we do see some systemic uptake is leukopenia. So we do see some drops in the blood counts. So we'll see a drop in the white blood cell count. We'll see a drop in the hemoglobin and hematocrit, and as well as platelet count. We typically see the side effect around day 7, between day 7 to day 10, and we usually see the nadir or the lowest point around day 10 to 12. And then typically we see a rebound after that. So in the majority of the patients that we see that leukopenia, we do not have to do any interventions like we do with when patients have neutropenia or anything during systemic chemotherapy, where we have to give Neulasta or anything like that. But because we do typically see the rebound, but that is one of the things that we see. And rarely do we have to give some sort of agent to bump the white blood cell count back up. One of the other side effects of mitomycin C is ileus. So ileus means the bowels fall asleep. So I'm sure many of Chris, Adele, if you had, the HIPEC procedure, I'm sure you ended up with the NG tube in for a little bit of time after the surgery. And it's miserable. It's miserable for patients, but every patient after the surgery gets an ileus where their bowels just do not wake up. And in some patients, it takes 3 days. Some patients, it takes 5. Sometimes it takes up to 7 or 10. And my policy is you don't take that NG tube out until bowel function comes back. So, because it always ends up going back in. So I think one of the biggest side effects of mitomycin C is that it does cause some ileus where the bowels just do not work.
Thank you. Another question in the chat on for tumors that have hardened, what would be an approach to treating those?
So that's a great question. So, when we talk about pseudomyxoma peritonei secondary to low-grade mucinous neoplasms of the appendix, oftentimes we'll see a jelly substance, so it's very soft and it's easier to remove. Some of the harder tumor implants, again, most of the time, if it's a low-grade process, we are able to remove those, and they are oftentimes, this is not very technical, but we can peel them off of surfaces of the bowel. We can peel them off the surface of the liver capsule, and they're peelable. In higher grade tumors, and this is why we do tend to be a little bit less aggressive in higher grade tumors, because some of those tumor implants that are firm and very hard are very difficult to remove. And they're invasive into, adjacent structures and things like that. So I would say for low grade processes, they tend to be more debulkable, even if they are firmer deposits. Whereas for patients with higher grade disease, it does tend to be a little bit more challenging. Does that answer the question?
Do we have examples in other diseases where we have some type of chemotherapeutic or immunological approach that can go after these type of hardened tumors?
There are some studies that are looking at injecting. There was one study that looked at injecting these tumor deposits with the cytotoxic drug directly, but it really didn't show much benefit. I did look at vaccinia virus, actually. Dave Bartlett does a lot of vaccinia virus work, and he was looking at direct tumor injection for colorectal cancer implants. And we did see some disease regression, which was wonderful. The best patients that respond to direct tumor injections are patients with melanoma. Those patients respond to immunologic therapy the best, as well as in direct injection therapies the best, compared to patients with colorectal cancer and appendiceal cancers. At least from the data we have so far. So there's not much that has been done in terms of directly injecting these harder implants, but I feel like more studies are being done to look at this. And there was one study looking at the use of, I think it was Pembro, which is an immunotherapy in the setting of HIPEC. And this was a translational science study. So this was done in 2014. And that showed really good benefit in patients, in the mice that received HIPEC with Pembro. So I think more studies need to be done, more clinical studies need to be done, looking at immunologic agents or immunotherapy. Not enough is known at this point.
Good. And I'm scanning, I'm looking for a particular patient too. I don't see her here today, but we do have a patient here. So I'm in San Diego at UCSD. They're doing a virus and an immunological approach. So we do have a patient who's doing that here.
Oh, awesome.
So work continues in that space.
Yeah. Is Joel Baumgartner
It's oh my gosh, I'll have to look to see the medical oncologist who's the lead on that. But Joel certainly knows about that study.
I thought it was Dr.
As does
Patel.
Patel,
maybe?
yes, I think that's the name.
Okay. Okay. I think I actually had a patient when I was at Mount Sinai that was going to see Dr. Patel about that trial, actually.
There's 4 or 5 centers doing it across the U.S. So
Yeah.
actually, the Ohio. Actually, you know what? I remember seeing from clinicaltrials.org.
Where in Ohio, Chris?
This center has actually completed their enrollment, so they're no longer doing it. But they were. Adele will tell you Ohio is the center. Look, there's Jen from Ohio as well. So
Yeah,
we have a
Toledo
lot of
in particular. Yeah.
Well,
So-
honestly, Ohio State, Jordan Cloyd has kind of created the HIPEC collaborative for a lot of the US HIPEC programs, and he's wonderful. So Ohio has a great program. So I'll put a plug in for them.
Thank you, Dr. McGee. Another question in the chat, back on the hard tumors. Could Bromac potentially be a benefit in dealing with the hard tumors?
I actually never, I honestly don't have knowledge in the use of that, to be perfectly honest. So I can't really comment on that. But I actually don't know the answer to that.
Okay, thank you.
A great question.
It seems to work well with the mucin, which I guess might give greater access, but I guess the hardened tumor, right, becomes a surgical approach, and the chemotherapeutic approach is it's difficult for that hardened tumor, I think, to get after it. Yep.
Hey, Chris, I'm sorry to interrupt. I just wanted to make a statement on that bromelain, because I've been looking into it really big, coming from Norris over there in Australia over to the US. What they're looking at is basically taking it and having it pull away from the organ itself, and then that's an opportunity to go in and debulk again. Or in some cases, it's really turning into mucus and it's pulling out of the tube.
One of my patients is probably going to enroll in the trial that's being offered for that. I just don't know the data behind it. I hope it's effective, but it's an interesting technique. I just don't know.
I have the results from Australia if you'd like to look.
Yeah, that would be wonderful, actually, because he was emailing me about it and I didn't have the data for him. So that would be wonderful if you could send me that.
Yeah, no problem.
Perfect. Any other questions before I keep going, or?
There was another question that came on really how do you monitor for recurrence once you've had CRS HIPEC? So
after having the procedures, what I typically do is every 3 to 6 months reimage with CAT scan or MRI. If your first diagnosis was made with MRI, I usually continue with that same imaging, but I usually do imaging every 3 to 6 months, as well as a physical exam, as well as tumor markers. So the major issue with this disease process is that CAT scan, MRI, PET scan, they really are not great tools at assessing disease, to be honest with you. And I find that in 50%, sometimes greater, of patients that have very minimal disease on their CAT scan, on diagnostic laparoscopy or other interventions, we end up finding a lot more than what was initially seen. So we definitely need better imaging modalities. There is a study looking at PET MRI, but it didn't really show much benefit over traditional MRI. So we need better imaging for it. But the traditional way of following patients for recurrence is with imaging every 3 to 6 months, as well as tumor markers. And there is a study that Colette Pommier is doing in Hershey, looking at second look laparoscopy in patients with high risk tumor biology. She's doing diagnostic laparoscopies a year out from the initial surgery. And so that is another trial that's being done to look at occult metastases in patients that are asymptomatic, that really have no evidence of disease on their imaging. So, but the traditional way is imaging plus tumor markers and a physical exam of the patient to make sure they're not having any significant symptoms that would explain for a recurrence.
Thank you.
Mm-hmm. So I'll go into, when I talk about maximal debulking, what does that mean and what do I consider a maximal debulking? So as I mentioned before, the studies had shown that in order for the drugs to work, in order for the chemotherapeutic drugs to work, we need to get the tumor deposits down to 2.5 millimeters or less in order for the HIPEC agent to actually be beneficial. So we have a score that we use, we call it a completeness of cytoreduction. And that score it ranges from 0 to 3. And 0 is what you want. 0 to 1 is really what you want. So 0 is not seeing any gross disease after your debulking. A CC score of 1 is having tumor nodules less than 2.5 centimeters, less than 2.5 millimeters in depth. So for CC scores 0 and 1, those are the patients that benefit from HIPEC. If more disease is left behind, so CC score 2 or 3, I do not give them the HIPEC because there's no benefit to that. So patients that I think are going to have a CC3, meaning disease nodules greater than 2.5 centimeters in depth, I do not proceed with a cytoreduction and HIPEC because they really are not going to get much benefit from that surgical intervention. The only reason I would intervene in that setting is for a palliative purpose to treat obstructive type symptoms, or if the omentum was quite large and was causing specific symptoms like early satiety or something along those lines, then I would partially debulk them or remove the area of concern. But in general, my rule of thumb is if I don't think I'm going to get a CC score of 0 or 1, I do not proceed with the big surgery. And actually, I did do a study looking at palliative HIPEC for patients that are not going to be maximally debulked and cannot have a CC score of 1 and 2. And we did see for patients with malignant ascites that the HIPEC did decrease the recurrence rate of the ascites. So we're actually going to be publishing this study probably in the next month or two, but there is some benefit for palliative HIPEC in specific situations, but it has to be very clear that that is not curative. It truly is to treat the specific symptom. So my rule of thumb is really CC score 0 or 1. I'll do the full Monty. If I can't do it, I will only do the HIPEC for palliative purposes. So I talked a bit about the pathology of the primary tumor and determining whether I'm going to do the big surgery or not. And these are some of the primary tumors that we do cytoreductive surgery and HIPEC for. So high on my list is appendiceal. I mean, those are the patients that we know benefit the most from these surgeries. And again, the low-grade mucinous neoplasms do the best from this procedure. And they have honestly the longest overall survival based on all of the data. We do also do cytoreductive surgery and HIPEC for colorectal cancer. And now it's in our NCCN guidelines, as well as our Chicago guidelines, to offer HIPEC for patients with peritoneal disease from colorectal cancer. So it's a big push from it. I still get questions of whether it's experimental, and it is not experimental. This is an accepted treatment course for specific patients with colorectal cancer. So it's a very useful adjunct for patients that have peritoneal disease from colorectal cancer. But again, patient selection is very important. So limited disease burden, low grade pathology, those are really the factors in determining whether a patient will really benefit from that surgery. Ovarian cancer, it depends on the center that you're at. So at Mount Sinai, we did a lot of HIPEC for ovarian cancer. Same thing in Pittsburgh. We did a lot of HIPEC for ovarian cancer. Here at Vanderbilt, we actually do not do a lot of HIPEC for ovarian cancer. And it really is based on the preference of the gynecologic oncologists and the data that they believe in. So, when I trained, it was before the New England Journal article that came out showing in recurrent ovarian cancer, HIPEC was beneficial, but I did a retrospective analysis at Pittsburgh and showed significant benefit of HIPEC in the setting of recurrent ovarian cancer. So we were doing a lot of HIPEC there for ovarian cancer. At Mount Sinai, that New England Journal article came out and we were doing a lot. But then here in Vanderbilt, they believe in a more recent study that showed no benefit of HIPEC. And they believe there were some flaws to that New England Journal article. So here we're not doing very much HIPEC for ovarian cancer, but there are 2 new gynecologic oncologists that are coming that do believe in it. So things may change in the next year. So we'll see.
Let me try and demystify some of that for the audience.
Yeah.
So what I heard Dr. Magge say is that different hospitals have different approaches. And certainly we've all worked, in our work lives, we find that different places do things in different ways. The people who have been there for a long time are, they can be appropriately and understandably set in their ways. And so, referral patterns from between physicians changed, right? So some hospitals, the physicians, the gynecological physicians think HIPEC just not is what we think is recommended. And we're hearing, right, studies that can conflict with one another. So while the science is amazing and the statistics are incredibly hard to understand, and they give us great power in understanding our diseases, right? We still get to these places where there's differences of opinion with our experts. So that's why it's important for us to be educated and seek the care that we're really looking for. Dr. Magge, did I do that justice?
I'll give you a personal experience. My cousin actually had ovarian cancer and with peritoneal disease. And her gynecologic oncologist did not believe in HIPEC. And this was actually at Mount Sinai. So she had seen a private gynonc attending that did not believe in HIPEC. And I became involved because obviously this was my cousin and I believe in it. So I actually asked for her care to be transferred to somebody else, because I think, everybody has different thoughts and everybody has different opinions. And you will probably get different answers from different people. So I do think it's important to seek out the care, but understand that there are going to be differences in opinions in management. And my opinion may differ from the next surgeon. My opinion may differ from Dr. Sugarbaker. It might differ from Dr. Bartlett on certain, patients, but it really, that's the tough part about medical care. It really depends on where you go. But for the majority of, appendiceal and colorectal cancer patients, most of the GI peritoneal disease surgeons do have similar opinions. I think ovarian cancer is really the one field that is very challenging right now, because it's almost like a 50-50 in terms of belief in HIPEC versus not belief in HIPEC. So it's a challenging situation right now for that.
As we return back to the presentation and look at some of these other diseases and the pathology and the planning, I just want us to have a sense of hope too, because I think as patients we go seek opinions, and we may get opinions from centers and institutions with incredible reputations, but it doesn't mean that it's fact, right? And so I have right, so that can be so disappointing for us, but for me, having lived in this world for 16 years, I have such hope and encouragement because we have physicians like Dr. Magge and others who are really fighting for us. And, there's different approaches out there, but we just have to keep seeking them. So anyways, it can be discouraging, but we want you to have hope and just keep looking for the care that you're looking for, because we think you can find it out there.
And I think that's so important, because I think I get a lot of patients that come and they ask, is this the end? Is this it? And I always say, no way. Because even if I can't offer you anything, somebody else might be able to, and there might be a clinical trial for you. So I always say, my answer is always no way. And even if I can't offer you something surgically, there may be something from the medical oncology standpoint. There may be a clinical trial in the pipelines that is going to come out that may be able to manage or help in some way. And so, I think the goal as a surgical oncologist, in my eyes, is really to offer that hope. And I never say there's no hope. I never have ever said that to a patient. So I have to reiterate that, because I think every patient deserves good care, and every patient deserves to be treated, equally. And I think there is different options for different patients offered by different centers. So if somebody says there's nothing that can be done, don't just stop. Don't just stop there. Just try to reach out to others. There's these support groups that are amazing, that really give different opportunities. And I just learned something about that trial from Australia. So, if I can learn something, anybody can learn something. So I think these are great, platforms for offering different things to different patients. So
this is wonderful. And I will tell this audience too, in a month, we do one physician presentation and 3 or 4 emotional support groups together, because the emotional journey, we think, is more difficult than the physical journey, as physical as this battle is. And we need that encouragement and time together, and just being with a group that understands what it's like to be us. And so we're here to support you, and you can get encouragement here. So with that, we'll go back to the presentation. Okay. And this is great.
Some of the other primary tumors that we do offer this surgery to are peritoneal mesotheliomas. And I had mentioned that we had a big population of these patients in New York because of a 9/11 due to the exposure to the different toxins. But the cytoreductive surgery in HIPEC has actually been shown to be very beneficial for this group of patients. So patients with this disease process, especially those with lower grade processes, do really well with after the surgery. So I'd like to put that plug in there. For gastric cancer, this is one of the toughest malignancies that we treat. And most of the data has shown very little benefit to cytoreductive surgery and HIPEC in patients with gastric cancer. But there is some new data that's coming out. Dr. Brian Badgewell from MD Anderson has been doing some amazing work with patients with gastric cancer. And he has a phase 2 trial right now looking at laparoscopic HIPEC for patients with metastatic gastric cancer with peritoneal disease at the time of their diagnosis. And he has found that I want to say he had his initial phase 1 data had, I think, 10 or 12 patients. And of those 12 patients, 50% went on to undergo their gastrectomies and HIPEC, their completion procedure. And so the HIPEC, the repeat laparoscopic HIPEC for those patients decreased their tumor burden to the point where he could do a complete cytoreduction on those patients. And he has had some survivors for over 2 years now. So I think the data is actually quite favorable for him. I think, in general, my policy for patients with gastric cancer that present to me with peritoneal disease is that they really have to show stability of disease before I would offer them any surgical intervention. So I typically give them a lot of systemic chemotherapy, and essentially they have to prove to me that they are not progressing while on chemotherapy, showing that their biology is favorable. And if they have very limited disease, and my PCI cutoff for gastric cancer based on a paper I wrote when I was a resident is less than 6. So very, very, very low PCI. If their PCI is less than 6 and they show stability of disease, then I would consider them a candidate for cytoreductive surgery or HIPEC, or I would put them on that trial. I would send them to Dr. Badgewell. So that's kind of my policy for gastric cancer. I'm very, very strict on gastric cancer. I don't offer HIPEC very often. So that's a little bit about some of the malignancies we treat with this procedure.
Gotcha. Dr. Magge, we had another question come in. Do you ever recommend systemic chemo for low-grade mucinous neoplasm after CRS HIPEC?
So adjuvant chemotherapy, you mean?
Yes.
Like after they've undergone the surgery?
Yes.
So it really depends on the final pathology. So if the final pathology shows a component, an invasive component, like a low-grade adenocarcinoma in the final pathology, I would recommend some adjuvant chemotherapy. The other time I do refer them to medical oncology is if there's a high-grade mucinous neoplasm of the appendix, even though the mucin deposits or the peritoneal disease is low-grade or acellular mucin, but the primary tumor was a high-grade mucinous neoplasm, I do refer them to medical oncology for consideration of chemotherapy. But sometimes what we find is in patients with low-grade mucinous neoplasms of the appendix, on final pathology, they do have a component of invasion. So for those patients, I do recommend seeing medical oncology. But if it's a straight low-grade mucinous neoplasm of the appendix, I do not recommend chemotherapy afterwards. I do surveillance. And it also comes down to the completeness of the cytoreduction. So if they were unable to debulk or unsuccessful in the procedure, then my concern would be that maybe there is an invasive component and that's why they were unsuccessful or unable to do it. So those are the patients I would also consider some chemotherapy.
Thank you.
So other things that go into preoperative planning for me and determining if a patient is going to benefit from the surgery, when I look at the CAT scan, and again, CAT scan can be, it's great, but it's not so great for peritoneal disease, unfortunately. But when it does show me a segmental bowel obstruction, or I see actual deposits on the small bowel surfaces, or disease involving the mesentery, I usually know that those patients are not going to benefit very well from the surgery. So I usually do a diagnostic laparoscopy on those patients to prove it. But when I see that on CAT scan, I usually know that those patients are likely not going to be a candidate for cytoreductive surgery and HIPEC. So that also goes into my preoperative planning a little bit. So sometimes what I would do, and I talk to each patient individually, for patients that I especially in patients who have higher grade disease processes or patients with colorectal cancer, I typically do the diagnostic laparoscopy on a separate date of the cytoreductive surgery and HIPEC. And the reason being is I will be able to get an answer for them in terms of whether I'm going to be able to do the surgery or not. Whereas for patients with low-grade mucinous neoplasms of the appendix, I usually do the diagnostic laparoscopy on the same date. Reason being is I'm usually able to debulk those patients if they don't have those imaging characteristics on CAT scan. So this is kind of the end of my presentation. I'll just, go over my conclusions a bit, and I can answer any questions that you guys have. What I wanted to really emphasize here is that carcinomatosis can happen from many different malignancies. And I think it's really important to have accurate pathology and to know the biology of the disease, and every pathology acts differently. Even though we use colorectal cancer outcomes and studies to influence our decision-making in appendiceal cancer, because it is such a rare disease process, every tumor has its own pathology and every patient has their own biology of disease. So we have to really look at each individual patient as an individual and make decisions based on that patient's biology and disease burden. I really want to say that there is a huge role for aggressive cytoreduction and HIPEC in the appropriately selected patients. So I think that is really important. I do not offer this surgery to all comers. I mean, I get a lot of consults for patients with really significant disease, but I need to make sure that that patient is going to benefit from such an aggressive or significant surgery, because if they're not, I don't want to harm patients. That is my goal as a physician and as a surgeon. And I think, I feel like sometimes that's lost. And I think, all of us want to help as much as we can. And sometimes we say we can do things that might not benefit the patient. So we need to be very selective in determining if a patient is a candidate for this surgery or not. Because if a patient's not going to benefit, it's a very big surgery to go through. And you really have to weigh the risks and benefits. The importance of high volume centers. I can't stress this enough. There are so many high volume centers throughout the country. Please, 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 go to an experienced physician, surgeon, medical oncologist. You will get great care, and they will have the latest and greatest trials. They will know how to treat you best. And, those are the ones who can determine if you are a candidate for the surgery. I think it's very hard when you go to a community hospital and they say, we have nothing for you, or we can't offer anything for you. That's why it's really important to go to an academic center with experience with this disease process that can say, hey, maybe I can't offer something for you, but this person can. This person at MD Anderson is doing this trial. Let me send you to him. This person at Hershey, Medical Center is doing this trial. Let me send you to her. So I think it's really important to go to a high volume center with experienced people. And it's okay if your surgeon says, I don't know, because a lot of this is, we don't know. And I don't know everything, and I don't pretend to know everything. And it's okay. But I think that's really the hardest part about this disease process, is that there are a lot of unknowns. But one thing I do like to do for my patients is I send all of my patients to palliative care. And it doesn't mean that we're not offering you anything. It does not mean that you're going on hospice and that we can't provide anything for you. But I think even though we're good at listening as surgeons and as medical oncologists, sometimes we're not. And I think the palliative care specialists are so good at listening to patients and discussing those goals of care, symptom management, things that I can't offer. So I send all of my patients to palliative care, and I think that really does improve outcomes, to be perfectly honest. I think that's even more important than the chemotherapy that patients receive. So that's one thing that sometimes higher volume centers also can offer. And that's why I stress that. And yeah.
Dr. McGee, I think you would support if you have a surgeon saying that you've got to get into surgery quickly and you're asking for a second opinion and you're being rushed. I think you would support saying it might be time to pause and maybe get some other opinions. And I think you should say that you don't mind if your patients seek a separate opinion too. You encourage that.
I 100% support second opinions. Like I said, you know, there's no ego in this. This is a patient care, and this is, you know, what can you offer the patient that's coming to see you? And I might not be able to offer something that Brian Badgewell can, or, you know, what Dave Bartlett can, or what Paul Sugarbaker can. I think, you know, second opinions are so important. I'm not saying go to 10 different surgeons and get different opinions, because I think that can be very confusing and overwhelming. Mm-hmm. But I do strongly suggest, if I say I can't offer you anything, definitely go to get a second opinion. And if somebody says we need to go to the OR right now and you're not feeling comfortable with that decision, a second opinion is definitely a way to go.
Dr. McGee, thank you. This is, I never cease to be amazed by my own learnings and the depth of the caring and honesty that our surgical oncologists bring. I'm so grateful for this presentation today. Thank you so much. This has been incredible. And
I'll show you. This is my son.
Yeah.
Just a personal side. He's 2.5 almost. So you know, that's kind of what motivates me, and my patients. You know, my family and my patients are really what motivates me to go to work every day. So I get joy out of it for sure.
Beautiful. Well, we are grateful.
We had a couple of other advanced questions, just 2 or 3, and maybe we could just get to those real quick. So we did have a patient, give you a little bit of the history, with multiple surgeries, including a colostomy in 2017, multiple rounds of chemo that ended in 2018. This patient's biggest issues are frequent and painful diarrhea that don't respond to medical treatments. Tumors are growing slowly but regularly. Could you give some advice to this patient?
Sure. So I think it's, do we know what the primary tumor is? Is it low-grade mucinous neoplasm?
I don't.
Okay. So in terms, do you know what care they're receiving or what kind of therapy they're currently receiving?
I don't know that either, no.
Okay. So I think my concern, if they're having frequent diarrhea or painful diarrhea, is this an obstructive process? And I think my concern would be that there likely is some sort of upstream obstruction from the colostomy. So if there is an obstruction secondary to a tumor implant, I think the management can be difficult. So I think what I would need to know a little bit in terms of a little bit more information is whether this is a low grade process and whether the disease is debulkable or not. Or whether this is a high grade process and the patient's on current chemotherapy. Because if it's a high grade process and surgical debulking is not an option, I would likely recommend a diverting ileostomy if they were having, frequent diarrhea from an obstruction. That would be maybe an option, or possibly a gastrostomy tube if they had recurrent bowel obstructions. That would be probably my recommendations. If they had debulkable disease and it was a low grade process, you could consider an operative intervention, but I would have to get a little bit more information.
Okay, thank you. This next question, and I do think you addressed some of it in your presentation, but again, when the cancer is in the small bowel, do you recommend being aggressive and risk having a miserable quality of life, or go conservative and hope for long-term chemo success? What are realistic expectations for long-term chemo?
I think that's a wonderful question. So as I mentioned, if for a patient to have a good quality of life after this surgery, you should have at least 200 centimeters of healthy small intestine in continuity. Because if you have less than that, you essentially have a short gut type anatomy, and you likely will require lifelong TPN, not tolerating diet, frequent diarrhea. It's a very difficult lifestyle. So if I'm unable to achieve that, I do not pursue, a complete debulking. And I think quality of life is so important. And that is why I do send patients to palliative care, because goals of care is very important to discuss preoperatively and to know what you want. And I think if you are going to have a very poor quality of care afterwards, and the surgery is not going to be quote unquote curative, it's going to essentially reset the clock, I would not recommend undergoing such an aggressive procedure to have such a poor quality of life afterwards. For long-term chemotherapy, so it really depends. So what I typically say is that with all the new testing, like Tempest testing, NGS, we're sending a lot of these tumors off for looking for different molecular markers and different things that we can target. So we do standard chemotherapy typically upfront for a period of time, and then give them a little bit of a holiday and see what happens with the disease process. And if they have progression while on chemotherapy or while off chemotherapy, we usually either put them on to something else or put them on to the same therapy that they were on previously. But you can't be on chemotherapy forever. First off, the body cannot tolerate it, and it usually does have some long-lasting side effects. So you really do have to weigh the risks and benefits of the chemotherapy. So what I typically say is if somebody has inoperable disease, I usually say at least 6 months of chemotherapy, assess with imaging to make sure they're not progressing well on that chemotherapy. If they do progress, then switch lines. And if they on that second line of chemotherapy, if they continue to progress, they should go on to a clinical trial. And then if they have a good response to the initial 6 months of chemotherapy and they become debulkable, then consider them for a surgery. If they don't become debulkable, I would say give them a holiday from the chemotherapy, see if they recur again, put them back on chemotherapy for another 3 months. And then if they have no signs of progression, take them off, give them a little bit of a break, and then see what happens. So, it's kind of there's unfortunately no science to it. It's almost kind of nuanced, and we take each patient individually. But in general, my rule of thumb is you can't really keep patients on chemotherapy forever. But with different targeting agents, we are seeing that, there are targetable actions on many of the tumors that we're getting biopsies of. So if patients don't have response to traditional chemotherapy, there are other options.
Okay, thank you. Wally, did you want to make a comment?
Just a real quick question. When you're talking about the chemotherapy, you're talking about high grade, not low grade, correct?
Correct.
Okay.
Correct.
I just was hoping maybe you had something that I had not found out yet, and I might be.
No.
Okay.
No, there's no great chemotherapy for low grade.
Yep. I didn't think so, but I thought, hey, at least ask. So
that's a great point. That's the hard part. I feel like we need better options for the low grade processes too. I just don't think they're out there yet, unfortunately. Right now, low grade processes or low grade mucinous neoplasms tend to be a surgical issue. But I do think in the future, you never know what's going to come out with different studies. I think most of the focus of studies are being done for high grade disease processes because low grade processes do respond really well to surgical intervention in general. So most of the studies that we're doing are focused on high-grade appendiceal adenocarcinomas. I know on some of our HIPEC calls, there's going to be one clinical trial that they're going to be doing. I want to say it's Ohio State. I can't remember. I think it was somewhere University of Cincinnati, I think, looking at high-grade appendiceal cancer and different chemotherapy options. But for low grade, we don't have anything right now.
Dr.
Thank you.
McGee, I was going to say, Adele, as we start to wrap up, I know I see more questions. I know there's other information, so I think we'll follow up with email after. There's one more question I want to get to as I bring us in for a soft landing at the end here. We have patients who had study reduction done, but never had HIPEC. And so, right, we're kind of in that watch and wait phase, right? And so almost to the title of the presentation, do we take an aggressive approach or not? What is the role of watch and wait, and how do we monitor and have surveillance? What are your thoughts?
So for patients that have already been debulked, my policy is I really do look at their CAT scans. And like I mentioned before, of course, CAT scan is not wonderful. But if it's a low grade tumor that has already undergone a debulking, either, by a general surgeon or gynecologic oncologist thinking it was an ovarian primary and it ends up being an appendiceal primary, what I typically do is I base it on tumor markers and CAT scan. And if I see any increase in their tumor markers or any changes on their CAT scan, I usually take those patients for a diagnostic laparoscopy. And I usually am relatively aggressive. Now, it really comes down to, again, the tumor biology, if this is a high grade process versus low grade process. For a low grade process, I tend to be relatively aggressive, but I do follow imaging and tumor markers relatively closely. The good thing about low grade processes are that they are very indolent. So if they've been maximally debulked, even without HIPEC, you have time. And I think to rush into an abdomen that has been operated on within the last 3 months, it can be quite challenging because of scar tissue. So what I tend to do is I don't necessarily rush to the operating room if I find one deposit of disease on their 3-month follow-up scan. I usually wait a little bit longer. So if on their 6-month scan, they have a little bit more disease, I usually wait a little bit longer, and I usually see what happens because it is a very indolent process. So I let the patient recover from that debulking, and I watch what happens on their CAT scan, and I wait till not necessarily they have significant disease burden, but I don't want to take them back for just one deposit, if that makes sense, because it's a big thing to have reoperative surgery. It's a lot harder than an initial surgery. So I usually tend to wait a little bit longer until I see more actionable tumor deposits that I can do something about.
More art and not science again.
Correct. More art. And, that's the tough part about this. It's not defined in textbooks. I mean, a gastrectomy is defined in a textbook, and how we manage gastric cancer, up T1, T2, T3, it's defined by our NCCN guidelines. But a lot of this stuff is very nuanced, and we take each patient as they come. And that is the benefit of also having a tumor board where we discuss really complex patients with our colleagues and with medical oncology and radiation oncology to really get the best plan for each patient. I know for a lot of my patients, I call my partner up and I'm like, what would you do with this? Would you operate? Even for patients that I take for a debulking that I do a diagnostic laparoscopy on, if I feel like I can't maximally debulk them, I will call my partner to confirm, because I don't want to be the end all be all, because everybody can offer different things. So, I think this is a very artful type of work. It's really not necessarily just in our textbooks, unfortunately.
Well, thank you. As I represent all the patients, thank you for both your humility and your expertise. We are not at our best when we come to see you, and we are very grateful in those times when we come to you. And thank you for sharing all of this today. It's been absolutely fantastic. We greatly appreciate it. And I'll encourage folks to use their reactions to give us some claps while we bring in our final slide and say thank you.
Yes, Dr. McGee, you were wonderful. Thank you so much.
Thank you.
As we wrap up, I will remind folks that we are here to support you throughout the week and at this same time every weekend for Hope Zoom calls. We have lots of programs to support, lots of classic programs from Bare Bottom Bears. You can always reach us at info@pnppals.net. Arthur Reddick's a retired surgeon and also a PNP patient, so he can help answer some of your more technical questions. Get Well Cards is our most popular program. Misty Price, the administrator of that program, is on the line today. And so we thank her for her work, and I encourage you to send an email and have those cards sent to you. And we have starter kits with important stuff you're going to need throughout the journey. We are donations run. We would ask for your donations and consider that. But thank you most of all for being here. And we hope to see you again next week. You can keep up with us online at the different forums you see here. And finally, in closing, I will remind folks, Yvonne, I did see your post, your chat. Thank you for being here. You never know what's going to happen. Yvonne is a signet ring patient, and I believe you had cytoreduction alone, not even HIPEC, and that was a long time ago. And let's see if I can find Yvonne real fast. Oh, he's unmuted. There. How are you, sir? Good to see you. In the end, we never know what's going to happen, but we've got great examples like Yvonne who can give us lots of hope, and we can look to for inspiration. So.
Yes, and Chris and Yvonne, I hope you don't mind sharing, but we have a picture of Yvonne skydiving shortly after his surgery.
Yeah. We never know what amazing things we'll do.
Mm-hmm.
Well, good. Well, thank you all for being here for the highlight of my week, Dr. McGee, you most of all. And we appreciate y'all. We hope to see you next week on the Hope Zoom call, and make it a great week, folks. Take care.
Bye, everybody. Thank you.
Bye-bye.